Let's see if this works better. I think I'm still moving, so I don't think I think you're still. I don't know why that happens. All I know is to just try to reshut down and see what happens again. Do you see me now? Okay. Yeah, I don't have any idea why it happens. I just know to try to go back in and out, and it usually stops whatever happened. All right, let's get started. So I told you that I have was that me? That's me. I don't know why I'm echoing. Do I still echo? No, I don't. So I have right here, I have a sheep brain, and you can see it's really, really quite little. I'm kind of shocked that a sheep brain is that little, but that's what I have. And then bear with me, I should have just brought it in here. I have, so when I asked for this butcher for these unfixed tissues, which I did it before the beginning of the semester, because I realized that looking at unfixed versus fixed, it's a whole different ballgame. And so I asked him if he could to get me some unfixed brain. And I knew that if he did it, it was gonna look kind of it has the texture of cold oatmeal, cold cooked oatmeal. And I knew that if he got it for me, if he was able to at all, he was gonna have to smash the brain, and it was probably gonna pulverize some of the brain anyway. Nevertheless, once I pull it out of this bag and we look at the fixed one, you're going to notice that they're very, very different in a lot of ways. When it comes to texture, having never really worked with dissecting unfixed organs until I started teaching online and started trying to look at what I could find and what I could get. I didn't realize that when you dissect fixed organs, you lose a lot because there's texture and things that you see in an unfixed organ that you don't see in fixed organs. And so we will play with this, or play with it, look at it. All right, we will play with it or look at it after we go through this PowerPoint. But yeah, just something to know that it's coming. I also, if we have time at the end of the semester, I have, so the way that I got to know this, I have some unfixed fetal pigs. And I got them because the reason I got to know this butcher is because one of my A&P students last year's husband is a butcher. And it's his dad it's their business. And so when they got a pregnant pig that came in, and unbeknownst to the owner, it was pregnant. And so when they went to butcher it, they realized that she had 8 fetuses. And so my student asked me, she said, do you want one? Do you want them? And of course I was like, well, yeah. And so if we have time at the end of the semester, we'll look at those. But right now for tonight, we'll look at these brains and see what we think. Let's jump into things. And if you got on and you looked at the PowerPoint earlier, I made some adjustments to it, and I just recently re-uploaded it. So it's only the adjustments were only made within the last hour. And so if it looks different than what it was before, there's a reason it does. So brain structure and function and the cranial nerve. So lab exercises 20 and 21. When you're looking at the surface anatomy of the brain, there's two major landmarks when you're looking down on it from a superior view. The first one is the longitudinal fissure, which is going to separate the 2 hemispheres. If you remember, this is what the falx cerebri is going to indent into. Separating the 2 hemispheres. The central sulcus, right here. With the central sulcus, there's a pre-central gyrus. Let me, before I say keep going here, let me say one thing that I don't think is here. Sulcus is an inner fold, so an indentation, or an inner fold. Is that the way to put it? I think that's the way to put it. An inner fold, meaning it's the bottom of a fold. A gyri or gyrus or gyri are the hills of the folds. So the top folded parts of the sulci. So hills or tops of folds. Plural for a sulcus is a sulci. So gyrus is the tops of the folds, and a sulcus is the bottom, the indentations of folds. I can't remember how your book describes it. That's the way I describe it. And it makes more sense to me to describe it this way than it does for me to try to describe it another way. Other ways. So when we're looking at the surface anatomy of the brain, each one of these right here is a gyri. The indentation here is a sulcus. This is a central sulcus, meaning it's separating, it's running down the center. And it's actually going to separate the frontal lobe from the parietal lobe. The fissures meaning a much deeper sulcus. So longitudinal fissure, central sulcus. The lateral sulcus right here, separating the temporal lobe from the parietal lobe and bear with me, separating, what are you doing, buddy? Separating the temporal lobe from the parietal lobe and the frontal lobe. Cerebellum meaning little brain. So cerebrum meaning big brain, cerebellum meaning little brain. And the brain stem leading down into the spinal cord. A little bit of a different view. This meaning just diagram, this being more of a cadaver. It's a very clean cadaver brain, but it is a picture of a brain. Here's the central sulcus. So right in front, precentral gyrus, the fold right in front of the central sulcus. Guys, remember this for a few minutes. This is a precentral gyrus. Here's the central sulcus. Here's the postcentral gyrus. One before the central sulcus, precentral before the sulcus, postcentral gyrus after the sulcus, and then the lateral sulcus. It's going to be important later.
I don't know if you've seen the message from Savannah.
Nope. What does it say?
She said she keeps getting kicked out.
She what?
She keeps getting kicked out.
She needs to call Hack. I can't. And the nice thing about Hack's IT Tech line is they are open, I think, 24 hours a day. It's also could be an internet issue at her house. Oh, did you tell her already, Zena?
No, I think she heard you. She said outside.
Awesome.
So.
Okay. The other thing is if she gets back on again, we can do it through the phone too.
She said she's in.
Okay. If Savannah, if you get kicked out again, do me a favor and call me, and we'll get you through even via the phone. So here's the pons, the medulla oblongata, and then the spinal cord. Looking at the meninges, and I know this is a little blurry, but I was trying to find a picture that was similar to one of the figures that you're going to see on Wiley. And this was the best I could do. So looking at this, very bottom, here's the pia mater. Remember, the pia mater is essentially transparent. You're looking through it. The arachnoid mater right superficial to the pia mater. In between the subarachnoid space, the dura mater. The periosteum is the inner lining. And remember, there's two parts to the dura mater. In the brain, there's two layers. One of them is analogous or is the same as the periosteum of the cranium. So we have two layers. This, the epicranial aponeurosis, we will see later because it has to do with the muscles, the muscle called the frontalis, which runs across the front, and it attaches the frontalis to the occipitalis, which is back here. But what I really wanted you to get from this was the meninges. So pia mater, arachnoid mater, in between them, the subarachnoid space, the dura mater cranium. So the dura mater is going to extend into fissures and form double layered folds. The falx cerebri is going to extend into the longitudinal fissure, and it's going to separate the two cerebral hemispheres. The tentorum cerebelli is going to essentially be over the top of the cerebellum, which would be underneath here. And it separates the cerebellum from the cerebrum. My way of remembering this is that the falx cerebri and the falx cerebelli are going to separate the two halves of the cerebrum and the cerebellum. The tentorum cerebelli serves like a little tent covering across the cerebellum. That's the way I can always remember them. So the falx cerebri separates the two hemispheres of the cerebrum. The cerebelli separates the right and left halves of the cerebellum. Let me know if you have any questions. This is another picture of showing a cadaver. So we know that, remember the dura mater, that's two layer folds. And within, when it's moving, when it's moving into the fissures, the one layer is like this, the bottom layer is indenting it. So this is a posterior surface. We're looking at it from posterior view. This is a superior sagittal sinus, which is right here or right here. And so it's a major place where cerebrospinal fluid circulates and blood pools. and where cerebrospinal fluid can be returned to the general circulation. It comes from so cerebrospinal fluid originates from blood and it returns to the blood after it circulates. And the superior sagittal sinus is one place where it returns. Transverse sinus is another place. It really can return anywhere in the subarachnoid space of the skull. But this is one place where blood and cerebrospinal fluid pools. Questions about that? I'm sorry, that was a much more complicated explanation than it needed to be. So superior sagittal sinus, transverse sinus. The superior sagittal sinus is following the area of the false cerebri. The transverse sinus is following the tentorium cerebelli. Looking at within the brain, we have internal ventricles. We have two lateral ventricles, and we have an interventricular foramen, which is a connection between the lateral ventricles and the third ventricle right here. Then there's a cerebral aqueduct, which connects the third ventricle with the fourth ventricle. The fourth ventricle drains into the central canal. And if you remember, the central canal is what we find in the gray commissure going down into the spinal cord. So there's 4 ventricles in the brain, 2 lateral ventricles connected by this interventricular foramen. The third ventricle, the cerebral aqueduct, and the fourth ventricle. You can hear the lateral ventricles, the third ventricle, the cerebral aqueduct, and the fourth ventricle, and the central canal. Why do we have these ventricles? Because part of the brain is hollow, and that's where these ventricles are, and they are filled with cerebrospinal fluid, which prevents the brain from collapsing in on itself. There's a structure, and I don't know, what, I can't remember what the purpose of this structure is, but it's called the septum pellucidum. And it's a clear membrane that's going to be separate and be in between the 2 lateral ventricles. Bear with me. I'm actually going to look because I don't know. And I'm going to do it on my phone so that I don't have to go back to the very beginning of the PowerPoint. Because I can't remember if it even has even if it has a purpose outside of separating the 2 ventricles. But I'm just curious. Function. Okay, it really is just a separating point of the two ventricles. It also contains a lot of white matter. A lot of what we're seeing in this mid area, including this corpus callosum, which is right here, is highly myelinated because it's what's connecting the two hemispheres. All right, you are not allowed up there, buddy. Sorry. I meant there's a reason I didn't bring that brain out, was because it would get my cats attracted to it, which is not what I want. They're not going to get it later. Ugh. All right, sorry. So now we're looking at a sagittal section. Here's, so right down, actually, is that a sagittal? That's frontal section right here. Where here's the two ventricles. The septum pellucidum right here. The corpus callosum, which we'll talk about in a minute, is a highly myelinated tract that we're looking at a half section of it right here. Here's the septum pellucidum, which separates the two ventricles. Here's the corpus callosum. Here's the septum pellucidum. So looking at this, here's the ventricles. Here's the corpus callosum. Here's the interventricular foramen connecting the two lateral ventricles. Cerebral aqueduct. Excuse me, not cerebral aqueduct, third ventricle, cerebral aqueduct, and fourth ventricle. Any questions about this? This is kind of smashed together, and I didn't mean for it to get smashed together, but looking at the flow of the cerebral spinal fluid, it gets secreted in the line anywhere where we have ependymal cells. They're going to secrete cerebral spinal fluid. This, I think this diagram is a little misleading. Actually, it's not too bad. But the cerebral spinal fluid is going to come from the ependymal cells that line all of the ventricles, the cerebral aqueduct, and the central canal. So cerebral spinal fluid gets secreted from what's called the choroid plexus, right here, choroid plexus, choroid meaning dark black.
Lena, my charger died. Do you know where my charger, my computer?
So choroid plexus meaning a dark, choroid means dark black, plexus meaning a network of vessels. So choroid plexus meaning dark black network of vessels. So the choroid plexus in lateral ventricle is going to secrete cerebral spinal fluid. It's going to flow through the interventricular foramen into the third ventricle. When it's the choroid plexus in the third ventricle is going to add even more cerebral spinal fluid. So now we're looking at right here. The cerebral spinal fluid is going to flow down the cerebral aqueduct into the fourth ventricle, which is going to secrete more cerebral spinal fluid. And then it's going to flow out via 2 lateral apertures and 1 median aperture and fill the subarachnoid space around the brain, in between the brain and the meninges, and the spinal cord, down and then around, and get retaken up by the what are called arachnoid villi. These little arachnoid villi right here is going to reabsorb the cerebrospinal fluid into the regular bloodstream. One thing that I didn't mention before, and I should mention it before we end with our discussion on the meninges. The neat thing about learning the meninges, this is what I think is neat, is if you've ever heard of people getting subarachnoid bleeds, epidural bleeds, are you familiar with, have you heard of something like that ever? Max, you've heard of it? Go ahead.
So when I worked at a nursing home, this lady, she had breast cancer and bone cancer, and she had fell and hit her head on her dresser, and I forget what they said she had, but I know she started having like spinal fluid filling up on the side of her cheek somehow.
Oh.
And I don't know if that's related or not.
It can be. I mean, I can imagine it would be a tear. So one of my favorite authors, I told you I like graphic, intense things. And one of my favorite, and some of you would probably say that isn't intense or graphic, but I like the Bourne series, the Bourne Identity series. I have all 4 movies. I've read a lot of the books. And if you're familiar with who started that series, you remember the movie Jason Bourne. Matt Damon is the best Jason Bourne out there. But if you're familiar with that movie, how many are you familiar with the movie Bourne Identity? Yeah. The author of the original book was Robert Ludlum. And right before the movie came out, he died of subdural bleed. What does that mean? Bear with me. I'm going to actually look it up and make sure I'm right that that's what it was. What does that mean? If someone dies of a subdural bleed, what does that mean?
Does it mean a bleed that happens underneath the dura mater?
Yep, that's what it means. And remember, you don't have an epidural space in the brain. Therefore, what happened, or a subdural space for that matter, what that also means is that normally there isn't a space there, but the bleeding creates a space. And so I'm going to look because I can't remember, and I've looked it up in the past. He didn't die of a heart attack. Now they're ruining it for me. Really? I was sure it was a subdural bleed. Okay, now I don't know what I'm saying. Never mind, guys. Let me give you another one. Okay, now I have to remember his name. Do you remember, you have to be old enough, Different Strokes? Do you remember the TV show Different Strokes? Who was the youngest boy? What was his name? Arnold something or other. What was his name?
Arnold Jackson.
Arnold Jackson. Yes, so if you look, his cause of death, and I know I'm right about this one. I thought I read somewhere that that's the way Robert Ludlum died. But Arnold Jackson died.
He had a form of an autoimmune disease.
Did, but the way he died, he actually went back and hit his head in the kitchen. He slipped. As far as they discovered, he slipped and went back and hit his head in the kitchen. Because I remember reading it and thinking, okay, well, that's where the bleeding occurred. Bear with me. I think it was
That one right there says Gary Coleman dies at 42, stricken with a brain hemorrhage.
But, you know, why would a brain hemorrhage occur? What do you think that is?
Bleeding on the brain.
Yes. And I thought, and I'm sorry, now I'm getting off on a tangent, but I'm going to stop in 1 second here. Epidural space. It might have been subdural. And you know what? I know I read it. I remember reading the newspaper article and realizing that it was a subdural bleed. And what it essentially, you know, it is a hemorrhage, but when you put pressure on the meninges, you put pressure on the brain. And I will find out later what exactly that all means. But this is one of those things where you, if you've ever been in charge of a child and had them go back, you know, fall off a stool and smack their head on tile. I mean, I don't think there's a single child who hasn't fallen off a chair at some point. But when they immediately fall asleep right afterwards, they start to cry and then they fall asleep. That's when you have to worry about these kinds of things. Is because it's bleeding within the meninges. And your cranium is pretty strong. But the meningeal bleeds can be pretty bad too. All right, I'm going to come off my tangent there. And I'll look it up later and I'll correct myself later about who I was sure it was Robert Ludlum, and now I've ruined it. I don't tell you how many times I've showed that, and now I realize I'm wrong. But so cerebrospinal fluid is going to come from the choroid plexuses and circulate, and ultimately it's going to lead back into the arachnoid villi and get reabsorbed into the bloodstream. Any questions or thoughts? So looking at another picture, here's your sagittal sinus, your superior sagittal sinus, the subdural space, which technically you don't have, you create it. You don't have it. It's, if you look it up, it's not a real space. It's a space that's created when there's bleeding. The dura mater, the subarachnoid space, and the pia mater. Here's another picture looking specifically at those sinuses. Superior sagittal sinus is on the top. The inferior sagittal sinus is towards the internal, so it's going to be separate. It's going to be right around the corpus callosum. This little area right here. So this approximately right here would be the inferior sagittal sinus. The straight sinus, where the inferior sagittal sinus, the superior sagittal sinus, and the transverse sinuses are going to connect. So this picture right here, I'm sorry, I'm shifting gears a little bit, but that picture right there is this, looking at this from a posterior view. The straight sinus would be right deep to this right here. So we were looking at about right here. And this is all going to drain into the internal jugular vein. So the cerebrum is the largest and most conspicuous part of the human brain. It's the site of sensory perception, memory, thought, judgment, and voluntary motor actions. In contrast to what we saw in the spinal cord, the gray matter is going to cover the surfaces of the hemispheres. And therefore, neural integration is going to occur on the surface. So in the cerebral cortex, cortex always means outer layer. So the neural integration in this brain is going to be on the surface. The gray matter, just like gray matter in the spinal cord, is composed of neuronal cell bodies, dendrites, and synapses. And the gyri are going to increase the surface area. Remember what the gyri are. They're the inner folds. Inner folds are going to increase the surface area. Within the center of the brain, we have a couple different tracts, major tracts. We have projection tracts. We have association tracts. And we have, I know we have one more set of tracks. Association tracks, projection tracks. And I think there's a track that we're not seeing here, and I'm trying to remember what it is. Transverse tracks?
There's a commiserate tract. Is that what?
Where is that? All right, that's
Right
it,
there.
commiserate
there.
tract. So
Okay.
this would, thank you, commiserate tracts, that's your corpus callosum. So it's what's, sorry, I appreciate you saying that. I kept thinking there's something missing here. So association tracts are going to be connecting different parts of the cerebral cortex together. Projection tracts are connecting different inferior parts like the brain stem and the spinal cord to the cerebral cortex. The commiserate tracts are that's made of the corpus, makes up the corpus callosum, is going to be connecting the two hemispheres. And remember, these tracts are these bundles of nerve fibers. Called bundles of nerve fibers in the peripheral nervous system, nerves. And in the central nervous system, we call bundles of nerve fibers tracts. So the two hemispheres of the cerebrum are connected by a white fibrous tract called the corpus callosum. It looks really white. You'll see it when we look at this fixed sheet brain. It looks really white. It's highly myelinated. And most often, you don't live very well without it. I had a friend in Idaho who, of his 6 children, 5 of them were born with corpus callosum atrophy, meaning that it was highly diminished. And his only living child that had this was 16. And his other children had died from seizures. And the one that I met, and it's not called, I think it's what's called corpus callosum agenesis, meaning it fails to develop. And when I met his son, who was about 16, he was confined to a wheelchair. It was nonverbal. And showed a lot of the signs of severe cerebral palsy. Except for he was completely nonverbal. And the dad let me know that this was, one of 5 children they had who had all been born with this, and they had all died from seizures. And so this connection between the two hemispheres is critical. So within the cerebrum, each hemisphere has 5 lobes, 4 of which are named for the cranial bones that overlie them, which makes them easy to remember. Here's the anterior side. Here's the posterior side. Here's the frontal lobe. the parietal lobe, the occipital lobe, the temporal lobe. And within the last several years, we have learned that there is actually an internal lobe called the insula, which is the lobe that we know the least about. But the frontal lobe is separated from the parietal lobe via the central sulcus. So the precentral gyrus is part of the frontal lobe. The postcentral gyrus is part of the parietal lobe. The lateral sulcus is going to separate the temporal lobe from the frontal lobe and part of the parietal lobe. So general summary of the functions of the individual lobes. You will see that there is some overlap here. So the frontal lobe specific functions. So now this is the posterior, this is the anterior. Frontal lobe is involved in abstract thought, explicit memory, mood, motivation, foresight and planning, decision-making, emotional control, social judgment, voluntary motor control, and speech production. The insula, the deep lobe, is taste, pain, visceral sensation, consciousness, emotion, empathy, and cardiovascular homeostasis. And I've never thought about it, but we will talk about later how the medulla oblongata is highly connected to cardiovascular homeostasis. And that makes me wonder just how much of the insula is considered, how much of the medulla oblongata and the insula are considered similar, or how much interplay is occurring between the two of them. One thing we learn about the brain is the more we learn about it, the more we realize how little we know. The parietal lobe is taste, just like the insula, taste, somatic sensation, sensory integration, visual processing, spatial perception, language processing, numerical awareness. Occipital lobe, in addition to the parietal lobe, is visual processing, visual awareness. Temporal lobe, hearing, smell, emotion, just like the insula. Learning, language comprehension, memory consolidation, verbal memory, visual and auditory memory, and language. So within these different lobes, so these are general ideas, and I can honestly tell you, I will never test you on these. It's a good thing to think about and recognize that they each are very different. But one thing that's more important is understanding these, tracking different functions to different areas. So starting right here, here's our central sulcus. Here's our precentral gyrus. Remember, that's right before the central sulcus, our postcentral gyrus. The precentral gyrus is primary motor cortex. meaning deciding how you're going to, what kind of motor action you're going to do. Motor association. How does that motor action relate to other motor actions you've done before? And how much does that relate to whether or not you're going to go through with whatever motor action you've decided to go through or you're thinking about? Broca's area is being able to move your mouth and your tongue to form the words that you want to form with your speech. The prefrontal cortex, judgment, emotional control, empathy. Starting back here again, looking back here. So here's the post-central gyrus, primary somatosensory cortex. So somatosensory, remember what somatosensory is? That's skin, bones, joints, muscles. So this is predominantly, it's going to be touch. So this is first recognizing that, for example, I'm here playing with my mouse, recognizing that I'm touching my mouse. First, bear with me. So primary somatosensory is recognizing that I have my hand around something that's smooth and plastic. My somatosensory association area is if I'm blindfolded and I've never seen this object and I feel it, how does it relate to what I felt in the past? And can I identify what I'm feeling based on what I've felt in the past? That's the way all of these association areas work with the primary areas. Is this clear? Am I making sense here a little bit? So primary is your first recognition that you're touching something, you're smelling something, you're seeing something. You're going to do something. Association is, how does it relate to what you've done in the past? And can you assess, identify, and decide based on what you've done before and seen before? So for example, my primary gustavatory, which is taste. Primary gustavatory and my gustavatory association cortex is not shown here. But my primary is going to be where I first taste something. My association gustavatory cortex is going to be with comparing that up and remembering other things that I've tasted, identifying what I'm tasting. Tell me this is clear. Somebody say yes or no.
So the association areas, they're more of like memory of things.
Or being able to identify. Yeah, memory
Okay.
based on what you being able to identify it and compare it to what you've done before and seen
Okay.
before. Okay. Wernicke's area works with Broca's area in that it's going to help you. It helps you plan out the way your words are going to come out. And putting them into a coherent sentence. So it's going to communicate with the Broca's area.
So does that have association with people with strokes when they can't talk properly? Is that the
It
brain
can
part
be-
that's affected?
It's predominantly the Wernicke's area. It can sometimes be the Broca's area because the Broca's area is what's controlling your muscles of your mouth and helping it. The Wernicke's area is helping you put a pattern together and also being able to recognize other people when they talk to you. Broca's area is specifically looking at the muscle regulation and the nerves and your tongue. So it depends on what's been altered. Wernicke's is putting words together and making them coherent, being able to understand what's being said to you, and also being able to understand what's being said to you, and also being able to communicate in an understandable manner. And Broca's area is specifically using your mouth, your tongue, and your muscles, and regulating how those are going to work together to allow those words to come out coherently. Does that make sense, Sam?
Yeah, thank you.
So primary visual cortex, visual association area. Same thing. First thing, you're seeing something, association, comparing it up against what you've seen before and identifying it for what it is. Primary auditory, this is probably by far for me, this is one of the easiest ones, is because it's in the temporal lobe. And of course, so your temporal lobe is right next to your ears, which is very helpful in remembering. So primary auditory and auditory association area. And you will see the auditory association area is very close to Wernicke's area. Remember what Wernicke's area is for. It's for helping you recognize words when they're connected together. Also recognizing, as I learned just last semester, recognizing a spouse's speech versus someone else speaking to you. Recognizing when your mother or father talks to you versus someone you've never met before. So this is talking about what I just kind of went through, but the frontal area includes the primary motor cortex and the premotor area, coordination and planning of movement. In the temporal lobe, the primary auditory cortex, awareness of auditory stimuli. The auditory association cortex is processing, analyzing, understanding, recognizing, and memory of sounds. Wernicke's area is comprehending, understanding written and spoken language. So Wernicke's area isn't just what you hear, it's also what you read. Yes, but Sam, with relating to your question about the strokes, that's why understanding what each of these areas does is so critical is because you can figure out, you can get a general idea from this, what symptoms someone is showing, possible ideas about what areas have most likely been affected. Looking at the parietal lobe, primary somatosensory cortex, so awareness of somatic sensations, touch, pain, and temperature. The somatosociation cortex, processing, analyzing somatic sensations, memory of sensations, recognition of sensations, and proprioception. Remember what that was from the other day. Being able to recognize the location and positioning of your joints in space. Posterior association area, visual, auditory, and somatosensory areas are going to meet. Also including this part of this would be the Wernicke's area too. And spatial awareness of the body. A lot of these, you'll see there's significant overlap. In the occipital lobe, primary visual cortex, awareness of visual stimuli, visual association cortex, being able to process, analyze visual info, understanding visual stimuli, recognizing it, and memory of visual stimuli. Any questions? I think sometimes this is probably the most fascinating part about this semester, is when you start recognizing what parts of the brain are doing what. So all of this different parts of your brain, summing them all together, one thing that we learn is that the integrative functions of all of these regions coming together is much greater than the sum of all the parts. Because integrative brain functions like sleep, memory, cognition, emotion, sensation, motor control, and language involve interactions between the cerebral cortex and basal nuclei. Remember what basal nuclei are in this case. Nuclei, when we're talking about the central nervous system, are clusters of cell bodies of neurons. The brainstem and cerebellum. Functions of the brain, as we've seen, as we saw here, do not have easily defined anatomical boundaries. The integrative functions of the brain focus mainly on the cerebrum, but can involve combined actions of multiple brain levels. This is, Max, you asked at the very beginning, I think you were one who asked at the very beginning of the semester about PET scans specifically. Do you remember asking about that?
I think.
This is a figure that I got, it says it came from the UMN, University of Minnesota, showing PET scans during certain activities. So passively viewing words, it's going to be in the occipital lobe. Listening to words is going to involve the primary auditory cortex, the association auditory area, or auditory association area, and the Wernicke's area. Speaking words is going to involve the Wernicke's area and the Broca's area. And possibly looking at this, some of the primary motor cortex. There's motor activities of your mouth. Generating verbs, Wernicke's area and Broca's area. This is just a figure that I got from looking for different figures that I could apply to this this lab. You hear language. It strikes the auditory nerve, which moves into the auditory cortex, which then compares that language in the auditory association area, which then works with the Wernicke's area. And then your response requires the Broca's area. Any questions? Okay. The diencephalon, do you remember what structures make up the diencephalon? The thalamus, the epithalamus, which includes the pineal gland right here, which is going to secrete melatonin, help with your 24-hour circadian rhythms, and your hypothalamus. This figure is showing how the diencephalon is integrated into the ventricles. Here's your lateral ventricle. Here's your third ventricle. Here's your fourth ventricle. Here's the cerebral aqueduct. And your pituitary gland, which we'll learn later, is attached to your hypothalamus. Zena knows all about this because the hypothalamus and the pituitary gland are major players in the endocrine system, which you'll learn all about in Biology 122. So this is just showing a different section, showing the different parts. So the corpus callosum, the septum pellucidum, the thalamus, the epithalamus, the hypothalamus, the pituitary gland. We have what's called the corpora quadrimanum. We'll see them on another picture. They look like 4 little bulbs, which serve for visual and auditory reflexes. Your mammillary bodies, which are actually involved in emotion and learning. So lateral ventricles, third ventricle, cerebral aqueduct, fourth ventricle. The limbic system, very important center for emotional learning. And three main components: the cingulate gyrus, which is going to be right above essentially right above the corpus callosum in the frontal and parietal lobes. The hippocampus, which is what's most attacked in Alzheimer's, is in the medial temporal lobe. And the amygdala, which is involved in emotional functions. These other components are also involved in the mammillary bodies, emotion and learning. Olfactory bulb. What do you think the olfactory bulb is? Somebody take a guess. What do you think it has to do with?
Because it was her ear.
What you're close, not auditory. What else could be olfactory?
Your senses like smelling.
Your sense of smelling. So how many times, if you smell something, does it relate to a memory you have, one way, good or bad? Are there certain smells that you love because they're associated with a good memory?
Like there's this smell of like my grandparents' old house that, you know, sometimes when I go in like vintage stores kind of remind me of that.
Yeah.
So even though it's not the best smell, it brings back, you know, like memories of people I love. So
Right. Right. Yeah, I don't drink coffee. I've only tried it one time and it was such a wake-up call that I can assure you I will never drink it again. It was so bad. And from what I hear, I probably just didn't get something that was very good. But for me, it was pretty. I got a coffee and a hot chocolate. When you see me drinking something, I'm drinking hot chocolate. It's a really good stimulant for me. But my grandma used to drink coffee, and I remember her house always smelling like coffee. And so I have like coffee flavored lip gloss because it smells that good. But, and I love the smell of it. I never want to drink it again. That was that one swallow I got when I got a hot chocolate for myself and a coffee for my friend. And then I messed up the cups. That was enough for me to realize I never wanted to drink it again. But the smell of it is pretty amazing. I love the smell of it. The reason it's such a part of your learning is because it's part of the limbic system, your emotion and your learning. Another one, I'm kind of weird like this. I had a lot of surgeries as a kid with my cleft lip and palate and my ears and other issues. And so one thing that I can't stand is I can't stand the smell of foam, those things that you put cold drinks in, those foam insulation things. You've seen them before, that you stick like a 12-ounce, 16-ounce can of something in to
Like a
keep it.
cozy?
What?
Like a cozy?
Yeah,
Like koozie or whatever they're called?
yeah.
Yeah.
I can't stand the smell of those things. And they almost give me almost a sense of PTSD because they smell like hospital anesthesia to me. And I dislike it so much that it's the same reason that I won't do gas in the dentist's office. I prefer they just give me a bunch of injections rather than put something that stinks over my nose. And it's for that same reason. So if you think back on that, you know why your sense of smell is so attached to your sense of emotion and learning. So limbic system is going to consist of portions of the frontal lobe, the temporal lobe, the hypothalamus, the thalamus, basal nuclei, and other deep nuclei, and associated with the sense of smell. It functions in controlling emotions, producing feelings, interpreting sensory impulses, and facilitating memory storage and retrieval, including learning. And major motivations. Your mouth starts to water when you smell something that you know you like to eat. So motivational based on your sense of smell and what you've smelled before, and you know that it tastes good. The thalamus is your gateway to your cerebral cortex. This is the grand relay station. Remember how those first order nuclei synapsed here in the sensory tracts of the spinal cord? So they synapse here, and then they're relayed to a particular area of the cerebral cortex to be interpreted. Motor information from the cerebellum, which is a major player for coordination and planning on and feedback based on motor skills, is relayed through the thalamus to the primary motor area of the cerebral cortex. Remember, the primary motor area is in the frontal lobe and that precentral gyrus. Sensation, somatosensory is postcentral gyrus. Motor is, primary motor is precentral gyrus. Your hypothalamus is your major control center of the endocrine system. It's going to control hormone secretion, regulating the anterior pituitary, which hormones coming from the anterior pituitary are going to be regulating growth, metabolism, reproduction, and stress responses. The posterior pituitary is regulating labor contractions, lactation, and water conservation. And the hypothalamus is attached to the pituitary via a stalk called the infundibulum. The midbrain is composed, has two major structures. The corpora quadrimina, and I know this is a little blurry again, and the cerebral peduncles. The superior colliculi, if you remember, I brought these up before, the corpora quadrimina, quad meaning four. So here's the superior colliculi, the two superior colliculi. Here's the two inferior colliculi. The superior colliculi are involved in visual reflexes, being able to track an object that's moving away from you, or track an object that's staying in one place as you're moving. Your inferior colliculi is when you jump and turn your head towards a loud noise. Those are your auditory reflexes. I don't think I scared any of you guys, but I know I scared my cats that are all around me because we have no dogs here tonight. The cerebral peduncles contain the substantia nigra, which is part of what's called the basal nuclei. Is that right? Basal ganglia? I think not basal nuclei, basal ganglia. So the cerebral peduncles are going to contain the substantia nigra, which looks black. That's the term Niagara. It looks black. It's a motor center area that's going to relay inhibitory signals, preventing unwanted movements. Degeneration of neurons in the substantia nigra is what leads to muscle tremors of Parkinson's disease. If you've ever noticed someone with Parkinson's disease, if you ask them to focus on a particular movement and look at it, they stop tremoring. Because Parkinson's disease is attacking the substantia nigra, which is involved in inhibiting unwanted movements like tremors. People with Parkinson's disease, at least I've heard of it, people with Parkinson's disease can do brain surgery. They can do fine motor coordination, as long as they're focusing on what they're doing. But you can't focus on all of your movement all at the same time. That's why we don't have to, because of the substantia nigra. Questions, thoughts? Pons means a bridge. It's this object right here, which consists of nuclei and tracts. Remember, nuclei are cell bodies, clusters of cell bodies in the case of the central nervous system, and tracts, myelinated fibers. It's going to relay stations because it's a bridge connecting the spinal cord with the brain. It's going to relay nerve impulses related to voluntary skeletal movements and coordination from the cerebral cortex to the cerebellum. It also contains the pneumotaxic center controlling breathing rate. And contains cranial nerves 5, 6, 7, and 8. The medulla oblongata, as a lot of people want to call this contains the nuclei for all of your major autonomic reflexes, which is not true. If you consider that your hypothalamus is actually a major controller, this is not it. However, when it comes to your basic functions, your heart rate, your breathing, your ability to swallow and cough, these are all in the medulla oblongata. So your cardiovascular center, controlling the rate and force of your heartbeat and the diameter of your blood vessels. Your medullary rhythmicity center, controlling the rate and volume of your breathing. This is what opioids act on. If you've heard of people who have gotten an opioid overdose, this is where it's acting. I learned from experience. I told you about my car wreck. when that happened, I had an opioid overdose in ICU. And as a result, I later, when I started really studying anatomy and physiology, I wanted to know why and how that occurred. And found out the specifics, and in general, what it means is the opioids work on this area and they slow it down. And that's why people die of opioid overdoses. If you learned about the recent guy, if you're a fan of the Foo Fighters, you know the group. It recently died, most likely from an opioid overdose. Reading the few things I've read in the tabloids. Vomiting, coughing, hiccuping, deglutition, meaning swallowing, and sneezing centers are also located here, and a bunch of other nuclei that we won't discuss. You guys, let's take a few minutes. I need to get up and move. Let's come back and finish this, and we'll do a little bit of a dissection.
Okay, thank you.
Okay, so let's take 5 minutes and just get up and move around. Mr. Evan. Okay, all right, let's jump back into this. So we talked about the cortical spinal tract when we talked about the spinal cord and upper and lower motor neurons. So upper motor neurons include the cortical spinal tract. So it's going to lie within the motor area of the cerebral cortex. Remember, that's going to be in the frontal lobe. And it's going to control the activity of lower motor neurons. So it's going to involve the primary motor cortex and the motor association area. Lower motor neurons are lying completely in the gray matter of the spinal cord and brainstem and innervate the skeletal muscles. They control the voluntary movements of skeletal muscles in the face and the periphery. And some examples are the spinal nerves and the motor cranial nerves. Talk about the cranial nerves here in a little bit. So lower motor neurons, remember they're in the brainstem and the spinal cord. Project to skeletal muscles, and they are going to innervate them, and when they're lost, the result is flaccid paralysis and atrophy of the muscles. Upper motor neurons are neurons in the cortex and other areas of the brainstem that project to motor neurons in the spinal cord and cranial nerve nuclei with a somatic motor component. The basal ganglia, remember that's where the substantia nigra that's affected by Parkinson's disease is found. The cerebellum and association areas of the motor cortex, which is in the frontal lobe, play a vital role in the choice, design, and monitoring of movement. But have no direct effect on lower motor neurons. So I find these little summary things, and I think they're great because comparing and compare and contrasting upper and lower motor neurons. I find these little things online. I think they're great to introduce because they can allow for more clarification. So an upper motor neuron is a motor neuron that originates from the motor region of the cerebral cortex or from the brainstem. A lower motor neuron is going to transmit nerve impulses from the upper motor neuron to the effector muscles. Upper motor neurons are located near the central nervous system. Lower motor neurons are located near the muscles that they innervate. Upper motor neurons are going to transmit nerve impulses from the brain to the synapses of lower motor neurons. So from the cerebral cortex to the synapses with the lower motor neurons, which are going to be in the brainstem and spinal cord. Lower motor neurons are going to form synapses with the muscles. Upper motor neurons are found in the cerebral cortex or in the brainstem. Lower motor neurons, their cell bodies especially, are found in the brainstem and the spinal cord. The cell bodies are bigger for upper motor neurons, and they're located in the brain cortex. Lower motor neurons, the cell bodies are small and located in the gray matter of the spinal cord and brainstem. Upper motor neurons are classified based on the pathway they travel in, like the corticospinal tract. Lower motor neurons are classified based on the type of muscle they innervate. Upper motor neurons are 6 general pathways. Lower motor neurons include the cranial and spinal nerves. Upper motor neurons are going to be involved in increasing muscle tone, hyperactive deep reflexes. As I messed that one up. Increased muscle tone and hyperactive reflexes are symptoms of damage. Symptoms of damage to the lower motor neurons are decreased motor tone, hyperactive deep reflexes, and muscle atrophy. So looking at how these correlate, upper motor neurons are going to originate in the motor cortex and premotor cortex, primary motor cortex and premotor cortex. The corticospinal tract, remember that's your voluntary movement. Corticospinal tract is going to pass through the midbrain and the pons. Most of the fibers decussate. Remember what decussate meaning, they cross. in the medulla oblongata pyramids. The upper motor neuron is then going to synapse on interneurons in the anterior horn of the spinal cord. And the interneuron is going to synapse on lower motor neurons. So as we learned the other day from someone who corrected me, and I'll tell you, when a student corrects you as a professor, you never forget what you were corrected on. But someone corrected me on the corticospinal tract. Remember, they're second order neurons. Can't remember. I think it was Christina or Elizabeth or somebody. Corticospinal tract passes through the midbrain and the pons. And is going to synapse in the spinal cord. The cerebellum plays a major role in timing motor activities and allowing for rapid and smooth processing and carrying out of those movements. It's going to monitor and make corrective adjustments to whatever motor plan you carry out. So you reach over to grab the chopstick, and when you reach out to grab it, it's going to decide how hard do you have to grab it. How strongly do you have to grab it? You go to pick up a pencil. Well, how hard do you need to pick up that pencil? You don't want to pick it up to the point of where you break it. So if you think about it, a lot of your fine motor coordination is training your cerebellum to how to put just enough pressure to do what you want and not too much pressure. The basal ganglia, remember, this is where the substantia nigra is also found, is going to help plan and control complex patterns of movement. It's not going to have any direct projections to lower motor neurons, but its movement is going to be influenced by regulating upper motor neurons. Questions? Are we all feeling as brain dead as I feel tonight? It just seems like we're a lot quieter tonight. Okay, because I can tell you I feel it too. Substantia nigra is a part of the basal ganglia that produces dopamine. So remember, dopamine is one of your major neurotransmitters. It's involved in playing a key role in the control of movements and preventing unwanted movement. That's where Parkinson's disease is involved. Because it sends signals to the cerebellum. And there's a healthy balance of dopamine that enables the precision of movement. When there's degeneration of the substantia nigra, there's less dopamine being produced and you have more unwanted movement control, lack of it. So here's your substantia nigra. and I may be saying it wrong, it might be Nigra. But this is what it looks like. Normally it looks very dark. In Parkinson's disease, it becomes very lightened up. It's not so dark. The cerebellum. Cerebellum, it looks like a white, actually, let me start differently. It has multiple folds to it. And just like the brain, the gray matter is on the cortex, on the outer surface, with the white matter inside. The fourth ventricle is right where the cerebellum connects up with the medulla oblongata and the pons of the brainstem and the midbrain. This little area right here, and it doesn't look so much like it here, but when we look at it in the sheep brain, you'll see it. It looks like a tree, a cross section through the half of this cerebellum. It looks like a tree. And it's called the arbor vitae. What does arbor mean? I know we've talked about this before. What does arbor mean?
Tree.
A tree. What does vitae mean?
Does it mean life?
It means life. So arbor vitae is essentially the tree of life. It's heavily myelinated. It looks white. And it's the tree of life that you see in the cerebellum. If you can have a favorite landmarking of the brain, this is mine. And I'm going to read this. I know it's blurry. So the cerebellum, remember, it's involved in planning and coordination of movement and processing to allow for precision of movement. So the cerebellum is going to receive input from the motor areas of the cortex via upper motor neurons and nuclei in the pons and ascending sensory tracts of the spinal cord. It's then going to process and integrate that input that it's receiving from the pons, the primary motor and association areas. And then it's going to send output to the upper motor neurons to connect with lower motor neurons. So it's receiving input, it's going to process and integrate that input. And then work to carry it out in a precise, coordinated manner. So someone locates, you look down and you see a pen. Visual information from your occipital lobe locates the target. The frontal lobe motor areas plan to reach the motor primary motor cortex and the motor association motor area. Plan the reach and command of that movement. The spinal cord is going to carry that information to the hand. Motor neurons are going to carry that information to the muscles of the hand and the forearm. The spinal cord is going to carry information back to the brain about sensory once you pick up that pen. And the basal ganglia and the cerebellum are going to judge how much force do you have to put into it and make sure that the movement is smooth. It's not like this, it's smooth. I don't reach out and grab somewhere up here or grab somewhere down here. I grab this. That's the cerebellum. The basal ganglia is how much force do I require. The sensory motor cortex is going to receive information that that cup has been grasped. So the basal ganglia and the cerebellum are going to choose which action is best used and how much force is necessary and allow you to smoothly carry out that action. Questions? Last part of this, the cranial nerves. Cranial nerves we have 12 to 11 and a half pairs of them. They start at the very anterior surface and they're named according to where they originate off the cranium. Spinal nerves originate off the spinal cord. Cranial nerves originate off the brain and brainstem. That's why they're called the cranial nerves. The first one, cranial nerve 1, is going to be the first one that comes off anteriorly. So here's where the eyes are. Cranial nerve number 1 is the olfactory nerve. The second one that comes off is the optic nerve, cranial nerve number 2. The third one that comes off is the oculomotor nerve, cranial nerve number 3. The fourth one is the trochlear nerve, cranial nerve number 4. The trigeminal nerve is cranial nerve number 5. The cranial nerve number 6 is the abducens nerve. Cranial nerve number 7 is the facial nerve. Cranial nerve number 8 is the vestibulocochlear nerve. Cranial nerve number 5 is the glossopharyngeal nerve. Cranial nerve number 10 is the vagus nerve. Cranial nerve number 11, which switches with the hypoglossal nerve, and we'll talk about the significance of this in a moment. But cranial nerve number 11, part of it comes off the brainstem, part of it comes off the spinal cord. But it's a spinal accessory nerve or the accessory nerve. Hypoglossal nerve is cranial nerve number 12. be able to identify each one of these. This is a picture, this obviously, this is a diagram, this is a picture of a cadaver. I like mnemonics for learning the cranial nerves. And if you go into Google and you say mnemonics for cranial nerves, there are about 4,000 cranial nerve mnemonics. This one is one. And it says, on occasion, our trusty truck travels, on occasion, our trusty truck acts funny. Very good vehicle anyhow. If that works for you, that's perfect. I'll tell you mine because I was a Harry Potter fan. I'm still a Harry Potter fan. It says, on they traveled and found Voldemort guarding very ancient Horcruxes. That's the way I remember them. But you want to remember what they're called and their order. And when we talk about the cranial nerves, we use Roman numerals. So on they traveled and found Voldemort guarding very ancient Horcruxes. Now I'll tell you the other mnemonic because my mother's not home. So I can tell you the one that I will never forget because I could not believe that my professor shared this in front of like 120 students. He said, oh, to touch and feel very good vagina, ah, such heaven. Guys, I'm not sharing it for you more than one time. You just have to learn it. I will not write that one out for you because when he shared that, I was in an auditorium of like 790 people or so. And he shared that and I was like, I can't believe you just said that. And I've never had to write it down. It's just there. So, but if you go into mnemonics for cranial nerves, there's like 12,000. There's ones that are related to fashion. There's one that's related to Abercrombie and Fitch. There's so many. Find one that works for you. The Harry Potter one works for me because if you've read the last Harry Potter book, that's what that book is about, is that they go on and they travel and find very ancient Horcruxes.
I want to go with what you said, but I don't want to make you say it again.
No, I can't say it. You know what? You can look that one up. I can't do it. I could not. I was so stunned when he said it that I've never forgotten it. Another thing that you want to learn about the cranial nerves is whether they're sensory, motor, or both. Whether they specifically serve sensory functions, motor functions, or whether they're both. Some say cranial nerves number 1 and 2 are sensory. Money matters. Cranial nerves 3 and 4 are motor. But cranial nerve number 5 is both. My cranial nerve number 6 is motor. Big facial nerve is both. Brother, vestibular cochlear, actually, wait, that's not right. Bear with me. Some say money matters, but my brother, okay. Some say money matters, but my brother says big bucks matter more. So sensory. Some say sensory, money, matters, motor, trigeminal is both, but my brother, motor, both, says vestibulocochlear sensory, big bucks, glossopharyngeal is both, vagus is both, matter more, accessory is motor, hypoglossal is motor only. So here's another picture showing specifically the different cranial nerves coming off of a cadaver, very well dissected out cadaver. And this is showing the 3 branches of the trigeminal nerve. This giving a general summary of what they're involved in. Olfactory smell, optic vision, oculomotor, trochlear, and abducens are all eye movement. Trigeminal is sensory and jaw muscles and teeth. Facial is facial muscles and taste. Auditory is hearing and balance. Glossopharyngeal is muscle of throat, larynx, and taste. Glosso meaning of the tongue, pharyngeal of the pharynx. Vagus, if you've heard of like Vega, the wonder of outer space. Vagus meaning everywhere. It's probably one of the most important nerves of the parasympathetic nervous system. It is the most important nerve of the parasympathetic nervous system. Hypoglossal, tongue movements underneath the tongue. Spinal accessory, muscles of the neck and upper back. Looking specifically at a sheep brain. Cranial nerve number 1, 2, 3, 4, 5, 6, 7, 8, 9 on this side, 10, 11, actually 11 down here. You got to remember they're flipped, 11 and 12. Looking at the hemispheres, here's the palms. So this is another one just showing the general summary of their names and what they do and whether they're sensory, motor, or both, and general functions. I'm not going to read through all this just for the sake of time. Telling you what cranial nerve number 1 does, specifically sense. This is what's highly affected in the limbic system. Remember, that's learning. The optic nerve is going to cross and it's going to go back to the primary occipital, primary visual cortex in the occipital lobe. And next week, because Justin's IV decided we really had to look at an eyeball, we'll dissect an eyeball. She didn't say it like that, but when she told me that's what her favorite thing was, of course we have to do it. different eye muscles are regulated by different cranial nerves. Let's spend more time looking at this next week. But right now, know that medial rectus, meaning medial, right down the middle. Rectus meaning straight. So they're the ones that are coming midline out. Lateral rectus are coming off to the side. You have an inferior rectus, which is coming straight down, and a superior rectus, which is coming straight up. And then you have a superior oblique, which is coming up above and making an angle and coming across. And an inferior oblique, which is doing the same thing from the bottom. It's coming across, making an angle and coming across. Coming down, making an angle and coming across. And the reason I want you to know the cranial nerves and what the eye muscles are innervated by different cranial nerves is there's a mnemonic for learning these. And it goes, LR6, SO4, AO3. And I looked at it differently. I was a chemist as an undergrad. And so what I say is I say LR, and I think of it like a chemical formula, LR6, SO4, AO3. And what that means is that the lateral rectus muscle of the eye is controlled by cranial nerve number 6, the abducens nerve. The superior oblique muscle is controlled by cranial nerve number 4. All others are cranial nerve number 3. Pretty easy if you think about it for a minute. And just remember, I think of it like a chemical formula, LR6, SO4, AO3. So lateral rectus is cranial nerve number 4, superior oblique is cranial nerve number, lateral rectus is cranial nerve number 6, superior oblique is cranial nerve number 4, and all others are cranial nerve number 3. So cranial nerve number 3 is going to control all of the cranial nerve, all of the muscles of the eye, except for the superior oblique, which is controlled by cranial nerve number 4, and the lateral rectus, which is cranial nerve number 6. It also is going to be involved in focusing the lens and the ciliary muscles. Actually, bear with me here. focusing the lens, and I think it's also involved in focusing the the muscles of your iris. So how much light is moving into your eye. Cranial nerve number 4, superior oblique. Moves the eye down and inward. The vestibulocochlear nerve. I missed cranial nerve number 7. Did I really? Cranial nerve number 7 is facial muscles and sensation of touch along the face and part of the tongue. Vestibulocochlear nerve is hearing and balance. Cochlear nerve is hearing. Vestibular nerve is equilibrium and balance. Cranial nerve number 5 has 3 different branches. It has an ophthalmic, meaning it's going towards the forehead and the nose, maxillary going towards the maxilla, and the mandibular going towards portions of the ear and jaw and muscles of mastication. This is the one that I think that when I wrecked my car, this is the one that I damaged. And I specifically damaged sensory to the maxillary and the ophthalmic. I didn't do the mandibular, as far as I know. If I did, it was just sensory, because I don't have any problems with motor. But I have problems with sensations. And I found where it comes through, and I learned this is one of those other perks of learning anatomy, is where it exits right in front of the ear, anterior to the ear. And when it starts to throb, which it does when I'm tired and when I'm dealing with allergies because it puts pressure on my sinuses. If I put pressure right here, I stop the throbbing, which is right where this nerve is coming out, which gives me a very strong indication that that's what I did, what's damaged. And I also learned when I first did it, when people would brush my face along my cheeks or my chin, it actually was almost like being shocked, and I did not enjoy it at all. Cranial nerve number 6, the abducens nerve controlling the lateral rectus nerve muscle. Some of your questions are going to ask you, these muscles, what directions do they, when they're contracted, how do they move the eye? These are your answers right here. Elevation, adduction. Adduction meaning you become cross-eyed. Inferior rectus meaning you're looking down. Lateral rectus meaning looking to the side. I'm going fairly quickly through this because I want to be able to do the dissection, so just be patient with me here. Cranial nerves of the eye muscles and movement. So another figure, this is this same thing in a different depiction. Medial rectus is going to move it towards the center, your eyeball towards the center. Lateral rectus to the side. Superior oblique, when you contract it, is going to move it inferiorly and towards the center. The inferior oblique is going to move it towards the outer side. So my inferior rectus is going to move it down. Inferior oblique is going to move it towards the center and up. Superior rectus is going to move it up when you're looking up. And we'll spend more time talking about this in a week. Another picture just showing the same thing. Cranial nerve number 7. Okay, so I didn't miss it. I just got things a little out of order. Cranial nerve number 7 has 5 branches. The temporal, the zygomatic, the buccal, the marginal mandibular, and the cervical. It provides facial expressions and taste. Salivary gland, innervation, tear, and nasal and palatine glands. And damage is going to produce sagging facial muscles and disturb senses of taste. Cranial nerve number 8, remember this is hearing and balance. Cranial nerve number 9 is going to be swallowing, gagging, and sensations to the back third, posterior third of your tongue. Glossopharyngeal, meaning your tongue and your pharynx. We will also spend more time talking about these in lecture also. Cranial nerve number 10, remember this is the vagus nerve, it's the wanderer. It is a mixed nerve and it's parasympathetic, slowing things down. Fibers are extending to the heart, lungs, and visceral organs. And some taste.
What is happening
Cranial nerve number 9, the spinal accessory nerve. This is the one that they recently, within the last 20 years, realized that it really wasn't a cranial nerve, technically, because all cranial nerves are supposed to come off the brainstem. This one is actually coming off, it's coming off, oh God, as I'm also my head dice. It's coming off, some of it is coming off the cervical plexus of the spinal cord. And they always thought up until recently that it was a cranial nerve. And then a bunch of people doing dissections realized that branches were coming off the cervical plexus, which meant that technically it wasn't a cranial nerve. But because it would mess up all the mnemonics, we have to keep it a cranial nerve. We don't want to mess up our mnemonics. No, it's partly because it still has it's got 2 branches. It's got one coming off the brainstem and it's got one coming off the spinal cord. This is a picture showing the same thing Here's your cervical spinal cord. Here's the branches of the spinal nerve and the branch coming off the medulla oblongata, and that they're merging together. So this is just a figure showing cranial nerves 9, 10, and 11. 9, 10, and 11. Cranial nerve number 12, hypoglossal, meaning it's inferior to the tongue. And this is just an overview of the cranial nerves. And you guys, I'm going to end it just like that. If you have questions, feel free to bring them up right now. I'm going to prepare for this dissection. And it won't take me very long. I'm just going to shift cameras. So yeah, if you have questions, please let me know. Recognize that we will go through the cranial nerves again. Not in as much, we'll go over more general views, more generals, but a review of it all the same. Where are my gloves? Oh, and the one thing I'll tell you, and we'll learn what hack decides that I can do and what I can't do. Okay, I know I had gloves. Where did I put the gloves? Shoot. Where did I put the gloves? Oh, they're right here. Is you can't dissect fresh organs at the schools. As far as I know. When I first started, I have never taught face-to-face for hack. But when I first started at Stevenson, I took some fresh organs in. And then because I tend to be overly honest, I told someone at the school that what I was doing and was told that I was not acceptable and I could not do it anymore because they worry about you bringing diseases or some whatever into the school that they can't control. And so I don't know after this summer if I'm going to be able to do it anymore. But we'll just see what happens. Oh, you know what? Tie my hair back. I don't want anything in my hair. So I'm gonna do the pig brain, the stuff that's not fixed first. Just to be able to compare the shape and structure of it.
Are you going to take the PowerPoint off so we can see
Oh,
a bigger
yeah.
picture?
I'm so sorry. Yeah.
That's okay.
Thank you for saying that. You see it now? Is it better now? Okay.
Yes.
All my in a row. Sherry, is that your spouse?
That is a great friend of mine. He's actually my ex-husband. He doesn't like to be called that, but we're great, great, great friends.
Okay. All right. That's awesome.
Hi, Pappy.
Give me 1 second. I'm just getting my tools ready. So I will tell you that almost all the tools that I've gotten for dissections, a lot of them I bought at Walmart. And so my scalpel blade is an X-Acto blade from Walmart. My tweezers are from Walmart too. My pan that I'm using is actually a dollar store kitty litter pan. And the only thing that I purchased online, I purchased the pad online because I wanted something that I could pin into and that I could reuse. And I have dissecting pins. And then I have a probe that I recently purchased online. But outside of that, everything I've gotten online. Everything else I've gotten at Walmart. So if you decide at some point you want to do some dissections, I would tell you to hit up the butcher that I talked with. Because outside of the lungs, they're the only ones that you seem to need permission to actually get. The only reason he gave me the lungs that I've used for biology 122 is because I was associated with HAC. But so this is the brain. And I thought that when I first saw this, I thought this is really bizarre. And I was amazed that he got it for me because I was not expecting him to be able to get it, but this is what it looks like. And it's kind of, it looks almost like cold oatmeal in its texture. There's some of it which seems to have a little bit more structure to it. You can see the folds in it. This right here, you can see that it's a little slippery. That looks more like that looks more like the arachnoid monitor. Because like I told you before, the PN monitor is really tightly adhered. It's not going to come off. If it comes off, it's going to come off before you even recognize that you pulled it off. But that is what it looks like, and that's unfixed. So that's just right after they butchered the pig. And I think that's interesting because you don't see that when you're looking at a fixed cadaver. You don't see that. It doesn't look like that. Justin, I'm still amazed that I don't traumatize her. Ivy, I'm still amazed. I don't traumatize her, which I think is awesome.
I love it. I am just so mesmerized.
Awesome. But yeah, so that's what it looks like. So now let's do the other, let me get out the other one. But yeah, it's just kind of slimy. When I told you that when I asked if he could do get me some brain, I didn't expect him to be able to do it. Because I thought he's gonna have to break the skull open to do that. And I think part of it might have been better structured if he hadn't had to break through the skull. But I will tell you that in the little pig fetuses that I have, it's got less texture than this has. So this is now moving into the sheep one. And I'll tell you, this is another thing that you do not have to, I did not, when I buy these, they come from a company in North Carolina. And you don't have to have credentials as a teacher to get them. All I do is, get like you would any other online purchase. I give them my credit card number. And you can get hearts, you can get lungs, you can get frogs, you can get kidneys. If you have a dog that will eat anything, don't put these things where they can get to them. Because I'll tell you, I told you we had a really old dog. Well, guess who ate a fixed kidney like 2 weeks ago? And he then thoroughly vomited it up for the next 24 hours. But so looking at this, here's your two hemispheres. Right here, one hemisphere, the other hemisphere. The longitudinal fissure. You can almost separate it out a little bit. This one's kind of tightly adhered. But there's the longitudinal fissure about right there. Back here, here's the cerebellum. Flipping it over towards the very top. So remember, this is anterior. You guys, I know we're going over time. If you need to leave, feel free to just jump off. So here, right here, so brainstem, medulla oblongata, and the pons. If I come up even further, right here, you'll see that there's a little crossing over. Looks kind of like a little cross where it would come out this way and this would come out this way. That's where the optic nerve is going to cross. It's called the optic chiasm. Chiasm mean, yep, that's her favorite. Optic chiasm, meaning where they're going to cross over. And so next week, when we do the eyeball, you'll see the end of the cranial nerve on the eyeball. And so it would be right about right here, and it would come up and it would attach onto the optic chiasm right there. So the eyeball would be about right here. And I want to see if we can see some things. Oh yeah, okay. Oh yeah. So what I've done is I've just kind of shifted down the cerebellum. And so right here, if you look right here, there's 4 little bumps. There's one right there. Tell me if you can't see what I'm doing. There's one right there. There's one right there. There's one right there, and there's one right there. The 2 top ones are the superior colliculi of the corpora quadrimina. The 2 bottom ones are the inferior colliculi. So the superior ones are involved in visual reflexes, and the inferior ones are involved in hearing. Any questions right now? The one thing about these brains being so little is it's hard to see a lot of things on them. There's a few things that I know how to find really easily, but there's a lot of things that I can't really find very easily. But I'm going to make a a sagittal's cut right through here. And I think, how do I want to do this? I think I want to do it right here. I'll tell you, when you do dissections, your best dissection tool is your finger. Because a lot of times, if you're not careful, you will tear through things that you're going to want to find later. Or you'll actually, let me say it differently, you'll cut through things with a scalpel blade that you maybe wanted to find. And if you use your finger, you're a lot less likely to destroy something you're going to want to find. So all I'm doing right now is I'm separating the two hemispheres. And I think I'm actually going to continue down, and I'm going to cut through the cerebellum all the way down. And it's not that it's very hard to cut. I don't want to cut through something that I'm going to try to see later. So I just made a cut just right down the center. And so now I'm looking at just a sagittal section through. And looking right here, if you look here, this is the cerebellum. So here are all the folds. And you can see that it's look kind of grayish. Give me feedback if you can't see it. It looks kind of grayish. The white in here is the arbor vitae. And I didn't make a really great cut. I'm actually, can I? Okay, kind of. If you look right there, do you see how black it looks? That's the lateral ventricle. And you remember how I was telling you how, one of my students in my anatomy course at Stevenson was like, well, what's all this black stuff? And I had to think about it because I didn't know. And then I realized, well, you know what? Because the cerebrospinal fluid is coming from blood, it's going to look black. And because the choroid plexus means that it looks black, it's going to look black. And so right here, all this area right here, right through here, is that it? Yeah, it is. That's the corpus callosum. Right through here. I'm going to try to move away just some of this. And if I'm really careful, hopefully I can do it without destroying something. Because I think right here, actually, let me do a little differently. Okay, that really didn't help me very much. But that's also right there, we're looking at a ventricle. That whole little internal area. Oh, you know what? There it is. There it is. So this right here, this whole structure right here, what I was telling you was probably a lateral ventricle. And mind you guys, sheep anatomy is not my thing. So when I'm looking at something this little, I have to think about what I'm looking at, and I do make mistakes. But what I was showing you before, that's a fourth ventricle and a third ventricle. And the reason is because when I cut deeper in there, if you look there, I have two openings. You see that one of them is black right here. And then there's another one down here that's black also. Am I just seeing things, or does that make sense? Someone nod and say yes. Okay, so this right here, this is the brainstem. So remember how here's where the fourth ventricle would be. Here's where the third ventricle would be. This right here is the lateral ventricle. So fourth ventricle, cerebral aqueduct, third ventricle, fourth ventricle right here. This area that's heavily myelinated, that's right around here, that's the corpus callosum. And honestly, now that I cut that a little bit more, you can see the arbor vitae a lot better than you could see it before. I'm going to make one more major cut. I'm going to cut right through one of the hemispheres. So if you look there, there's all your white matter with your gray matter on the outer on the cerebral cortex. And just looking at it, putting these two together, let's see, how did it go? It went like this. Putting these together, this right here would be one of your projection tracks. This is spanning from here over into here, would be one of your association tracks. And the one that's separated is connecting the two halves is your commensurate track. Commensurate track. Is there anything that you want me to try to find? Looking at this other side, I can see a lot better into the third ventricle. Sorry, not the third ventricle, the lateral ventricle. Ivy, what are you wondering about? She's the big face I can see. I can tell she's saying something. What are you seeing?
I don't know.
She likes the arbor vitae. That's her that was her favorite part.
You know, that's mine too, actually. That's my, I like that one too because it's so obvious. It's so obvious. Is there anything that you'd really like me to be able to point out? Or I can try to point out? Okay. Let's, I really, I don't know what else I can find here. But we will do an eyeball next week. And we will yeah, there's one thing that if you're interested in doing this with kids, dissect a chicken leg. Because it's amazing the stuff that you can find. Because realize that when you're looking at the meat of a chicken leg, you're looking at the muscle. And you can go through the bone marrow. But you guys have a wonderful night, all right?
Thank you so much.
We're doing this.
Say thank you.
Thank
you. Have a good night.
Bye, thank you.
Bye.
Bye.
Have a good night.
You too.
I know we discussed on Monday what was due. Are you going to be sending out an email this
I
week?
will.
There,
I don't know when I'm gonna get it sent out.
It's okay.
Today I ended up taking over for another professor, and it's been kind of a chaotic day. It might be this weekend, but
Okay.
let me tell you what so you were around when we shifted the due dates, right, Jennifer?
Yes.
So this stuff, chapter 20 exercises, and I realized I could combine them. There's just one, chapter 20 and chapter 21.
Yes.
And they will be due next Tuesday night.
Okay. And then I also wrote down the next one as well.
What? That it should be open for you, and it will be due the following Wednesday.
Okay.
The following Tuesday. I opened it for you last night, so if you have a problem opening it, let me know, okay?
Okay.
And I think what we decided, if I will do my best to get an email out on Friday. Would that be early enough?
I think anything would be okay, even if you did it on the weekend, because I mean, I generally know what we need to do. I just like it when I start to question myself because of the due date always matching, like that I'm doing exactly what needs to be done. So
I understand that. I will probably put out another case study. I need to go through and remember what case study I wanted to put out and make sure that it's got questions that I really want on there.
Okay.
And I will put out an email when I put it out.
Okay. Did speaking of the case study, because I really didn't know if I was doing it right. Did you grade the
I have not graded it yet.
Okay. Just curious, because if I go to do the next one and I'm doing it wrong, I would
You know what? I actually, now that I think about it, I know what the second one is going to be. And it's, oh yeah, I do. I know exactly what it is. It's going to be cranial nerves.
Okay.
You know, I'll post it tonight. I can do that in a hurry because, and what when you look at it, a lot of that information, you're going to get it from the lab.
Mhm.
You're going to get some information from the book. But if you can't find it, let me actually, bear with me. I'm going to show, let me see if I can't just show it to you, Jennifer, because you're here and I know you're having eye surgery. So let me